Good morning, everybody. Welcome. Thank you for joining us again this morning on what feels like it could be maybe the first day of spring, a little bit springy. We will start, as we always do, by talking a little bit about the numbers. And you remember I talked last month about sort of what we were seeing here and the need to really double down on our efforts. And it does appear that is, again, keeping in mind, as we always say, that one overdose is really too many. It does appear that we are starting to make a little bit of a gain back to where we were here. We saw, since we last were together, which was February 24th, there have unfortunately been 16 fatal overdoses across the county, which means that since January 1st, we've experienced 55 non-suicide overdoses across the county, which is exactly where we were last year at this time. And that is a good thing, unfortunately, given the dramatic increases that everybody else is seeing, as you may have seen some of those numbers that came out this week. And what we did see in February, which is a very positive thing, is that during the month of February of 22, we experienced 15 overdoses across the county. Last year in February, much deeper in the pandemic, we had 24 during the month of February. And that contrasted sharply with where we had been the year before, which was at 15 and 13. And in 19 and 20, we were at 15 and 13. So just before the pandemic, February of 21, which is really the first February in the pandemic, we're up at 24. We brought that back down to 15. So it just reminds us, as though, no, I know many of you don't need a reminder because you see it every day, but where we are with all of this and the need to continually be vigilant. I want to talk a little bit, since it is Women's March, is Women's History Month, about thinking about women's health care, again, women being 51% of our population, and also providing an enormous amount of health care. I think if you think about some of these numbers I'm going to talk about, which is really pretty impressive, there are 16.4 million women in this country that are employed in either healthcare or social assistance. And that's 77.6% of the 21 million workers. So 21 million healthcare in that broad definition across the country. And 16.4% of them are, 16.4 million of them, sorry, are women. So enormous percentage. And women account for 75%, flat 75% of hospital employees. And 77% of all of those in healthcare services. And looking at, first of all, we've got an enormous number of women in healthcare, but then looking in our particular focus at substance use disorder, what we see is an interesting contrast. There are actually, as you might expect, more men than women who are in treatment for substance use disorder. However, women are more likely to be seeking treatment, having developed a dependency on either sedatives, sleep medication, or anti-anxiety medication. And unfortunately, in addition to that, although the number of men seeking treatment for heroin use has always been dramatically higher than the numbers of women, that number has unfortunately been climbing. And what we see is that substance use disorder progresses differently in women. Women report a much shorter history of using certain substances like cocaine, opioids, or alcohol. Shorter history and entering treatment with much severe symptoms. So we know that window of going from use dependence to a real problem is a much shorter one for women. And many women with, as you know, with substance use disorder are often also being diagnosed with other mental health issues. And the intersection of those and the treatments, which may not be coordinated, can often be making some of those conditions worse. Because the people who have both of those conditions being treated at the same time, they often have symptoms that are more severe, more persistent, and more resistant to treatment than one that has either of the other. So that's a very important piece of when we look at what are the treatment programs for women. We also know that women report using substances to relieve stress or a negative emotion at a greater level, and also are more likely to develop a substance use disorder, as you might expect when we look at trauma history following the divorce, the loss of child custody, or death of a partner or child. So, and of those women reporting a substance use disorder, more than 1 out of 3 have also been involved in a violent, intimate relationship. So again, just reminds us of the importance of all of our different areas of work and how they relate to each other. One of the things we've been doing a lot of looking at of late has been, and you may have seen the recent article in the New York Times, sort of the under discussed effect of both choking and head blows, which are often present in domestic violence situations. And there's a lot of new research going on showing that women who are later presenting either with some very serious health problems, but more often mental health issues or substance use disorders, have been the victims of head injuries consistent with people who played NFL football for a very long time. So they've been in a domestic relationship where their head has been banged frequently, or they're in a domestic relationship where they frequently have been choked and had oxygen cut off for periods of time. And there's a whole new focus on the correlation between those two kinds of violence and symptoms that people are reporting that have been for many years being treated very differently. And that is obviously without reaching the very unique needs that may exist for women of color. We know that African American and American Indian and Alaskan Native women are more likely than women of other racial groups to be victims of rape, physical violence, or stalking by an intimate partner. And we know the other piece, and I mentioned this developing research, what we also know is that women have often not been included in some of this clinical research based on two kind of misconceptions, one being that women were biologically more complicated and maybe they shouldn't be included in these studies, and secondly, that as caretakers for children, they might not have been as available to participate in that research. The National Institute of Health has developed the Office of Research on Women's Health. They established that 20 years ago in a recognition of the need to do that. I would say that we are only now starting to see a lot of that research come to fore. So before we turn to our presenters today, I want to ask Eileen Dern to tell us a little bit about an upcoming program. Many of you, particularly at our Mystic Valley Task Force, have worked with Eileen. She runs community programs at Melrose Wakefield, which has now become WellForce, which became WellForce and is now part of Tufts Medical. And Eileen is also the convener of the Mystic Valley Behavioral Health Coalition, of which our office. That coalition has sponsored a number of really terrific programs, and I give Eileen an enormous amount of credit. She has kept those things going throughout the pandemic. Some of the first Zooms when we were all learning how to do it were with Eileen's program. And they've really been addressing the stress of the pandemic on healthcare providers, as well as lessons around behavioral health and substance use. So Eileen's going to talk to us a little bit today about an upcoming presentation. So Welcome, Eileen, again.
Thank you. So good to see you. Exciting news. We are planning an event and it's coming up April 12th. It will be from 11:30 to 12:30 and we will be sending out flyers. It is on youth mental health. And we've been lucky enough to have District Attorney Ryan is going to monitor and be our kind of mentor for the program and facilitate the group. We are going to have superintendent of schools from the city of Medford will be there with us. She's a board member for Tufts Medicine, Melrose Wakefield. And we're very happy to have her there to talk about her perspective on the need for this support. And this is for providers of services for youth. So we're hoping that this will allow some of our local mental health peers to be able to have some support for the work that they're doing. And then we have been able to, for the last few years at Melrose Wakefield, fund some unique programs in the community. One is the SBIRT program, which is screening and brief intervention for mental health concerns under the Boys and Girls Club of Stoneham and Wakefield. And they'll be presenting on some of the success they've had with it. We fund part of the program and Leahy BI also funds part of that program. And it's been very successful. They told us yesterday that one of the students at Stoneham High School mentioned to his counselor that the people that were really keeping him going during the pandemic when he lost his mom was the people at the Boys and Girls Club. So money well spent. We'll also hear from the Family Center, which is run by Elliott Human Services. And the Family Center is located in Everett, but covers our whole service area. And it's a DCF funded program. And they now have a health law advocate there 40 hours a week to help families with the legal complications of trying to raise children, whether or not children, there's custody issues or whatever, they can really provide this free service to get the family started on a road to help. We're excited about that. And then we're looking to another community partner to talk about their home visiting program for family mental health. So the program will really be designed for all of us to help each other. We do have a psychiatrist, the lead child psychiatrist from Elliott will also be speaking to really talk about the concerns that District Attorney Ryan has talked to you about, the concerns that we know are coming in from the schools, and the concerns we all have as providers of what to do. When is it serious enough to reach out for another hand? When should we handle it ourselves? And it's very exciting to have this group convene. So it's the public health organizations locally, the district attorney's office, Melrose Wakefield, NAMI, the National Alliance on Mental Illness, and like I said, these wonderful community partners. There's about 75 partner agencies on the coalition. So I'm happy to answer any questions, but we'll be getting a flyer out to you, and we hope you'll all come. It will be a great opportunity to learn from each other. Thank you.
Thank you, Eileen. As always, a great program. And if you can, I recommend you turning into this. We're going to send the flyer out when it's available, and we'll have the registration. It'll give the registration information. So thank you.
You're welcome.
All right, turning to our presenters today. Our first presenter is Ari Manin. Ari is the founder of Boswell, and he's a former community health worker. He's worked with many of the neighborhood touch points, which include the churches, old clinics, the food pantries in Greater Boston. And as we all know, collecting data from those facilities is often very difficult, but it's really important. But you don't want the collection of data to get in the way of providing direct services. So Boswell is a social enterprise developing a free web application to meet those unique needs. And while it supports the mission of those organizations, a parallel goal is to facilitate the connections of guests and clients and customers of the pantry with healthcare. So I'm going to let Ari explain that to you. And Ari, thank you so much for being here.
Yeah, thank you, District Attorney Ryan, and thanks for having me. And thank you, Nora, for inviting me to this meeting. I appreciate all of your time here. Yeah, so as mentioned earlier, my name is Ari. I'm a former community health worker based out of the Boston area. I started out my career in a very different place. I was actually working in cancer research in Cambridge for a couple of years right out of college, and then realized I wanted to do something different, get out of the lab, and work more directly with people. So I quit in 2014, and I started working with churches, food pantries, mobile clinics, needle exchanges, kind of the spectrum of touch points out there, primarily Dorchester, Roxbury, East Boston, and Chelsea. And over the next 2 years, what I learned is that the majority of the organizations I was working with were using pen and paper. They weren't really technology enabled. There was a lack of infrastructure to do basic intake and reporting. And I was often the guy writing things down on a piece of paper, transcribing it to a spreadsheet, then compiling the numbers at the end of the month for reporting requirements to access funding, demonstrate the impact. So that was the first lesson. There's really a lack of technology at the front line. And the second is that there are incalculable missed opportunities to help people navigate their way to healthcare and social services through community-based touchpoints. And so I often share the story. The first night I was actually working in a mobile clinic in East Boston. It's actually the Outreach Van project run by the Boston University med students. Every Thursday night at 7 p.m., they go to the parking lot next to the Shaw's in East Boston, and they serve about 70 to 80 individuals, food, toiletries, clothing, just a trusted touch point. And the first person I met there was a guy named Huey, who at the time in 2014, he was 56 years old. He was homeless. He drank Listerine, which is pretty alcoholic, and he used to walk around East Boston in a green hospital gown because he went to Boston Medical Center 4 times a week. But like clockwork on Thursday nights at 7 p.m., he'd show up at this mobile clinic to get food, toiletries, just some support. But we'd write down his name on a piece of paper. We'd throw it away at the end of the shift. There was really nothing that we did about that afterwards. And so really what we're trying to do with Boswell is we're trying to build bridges from community-based settings to the healthcare system, but along the way, strengthen the safety net touch points that are serving people in need. And what we've done here, and I'll go ahead and share my screen, is we've built this free web-based application to streamline intake and reporting for food pantries. So nationwide, there are about 100,000 food pantries, and they converge into about 250 or so regional food banks, Greater Boston Food Bank being one of them. And if you look at Greater Boston Food Bank, there are probably 600 to 700 food pantries east of 495 that are primarily, using pen and paper, homegrown spreadsheets. Occasionally, they're able to pay for software to do this intake and reporting. And what we've done is we've just built a free, easy, customizable application for food pantries to streamline their operations. Along the way, our goal is to enable people that are visiting food pantries to also better access healthcare and primary preventative resources. So one of the really astonishing facts, and it's a real paradox, is that in Massachusetts alone, there are about 7 million people. 2 million of them are on Mass Health, so the Medicaid program. But just 60% of that population is actually engaged in primary preventative care. So what that means is that another 35 to 40% of members don't take their medication. They don't show up at the doctor's office. They're unreachable by their care management teams. In many ways, they're check engine lights that could become future Hueys down the road without earlier intervention. And I think as we know about people that have fallen through the cracks of any system, it's never really an overnight process for that to happen. It's just kind of missed opportunities compounded upon one another. And so we've done some pilots to date in Boston and also in Providence, where we've demonstrated that not only can food pantries use this application for free, and it streamlines their workflows, it saves them time, it enables them to be compliant with the reporting, but people that visit these touch points can be connected to care managers. And ideally, we can pave a path to primary care that's a little bit broken right now. And so, that's really the paradox we want to address, that, coverage doesn't necessarily equal access. Massachusetts is one of the most well-covered states from an insurance standpoint, but just like the rest of the country, we have this gap where, a third of members don't access services whatsoever. So yeah, this is our website, boswell.io. You can reach us through this number. You can chat with us. You can always schedule time to do another Zoom demo at your convenience. Briefly, I'll just show you. It's a dashboard for the food pantries to kind of digitize their workflows. So you can search for somebody, maybe Rhonda Revere as a client. She visits the food pantry, provides basic demographic information. These are the types of things that pantries do anyway, but it's often just on pen and paper or a homegrown spreadsheet. You can see like how frequently Rhonda's been to the pantry. You can provide assistance. Everything is customizable, configurable. And, as you expect, it's just capturing basic metrics. You can see the assistance histories here. And then it basically automates reports, right? And so for a food pantry, which is primarily volunteer driven, and increasingly in the last 2 years of the pandemic, many pantries have shut down, and the ones that have stayed open have seen an increased demand of people showing up. This is just simplifying all the numbers that they normally have to spend hours upon hours collecting each month. And so, yeah, that's really the goal: strengthen the safety net, improve outcomes for people in the community, and ideally create value for the healthcare system. by reducing these missed opportunities and saving costs for the payers and providers. So yeah, we're really just trying to build relationships in the community, and we currently have about 100 pantries using this application, primarily Vermont, Eastern Massachusetts, Rhode Island. We're looking into parts of Pennsylvania as well. But as I mentioned, there's 100,000 pantries out there across the country, so we have our work cut out for us. But yeah, I'm happy to take any questions and get any feedback, and always talk further offline if anyone wants to learn more.
Thank you. Questions, comments?
As usual, I have a question because it seems to be what I do is ask questions. So can you explain the connection, Ari, between this information and access to care? So how does this information get to care providers? And then similarly, what are the protections for the guests and customers of the food pantries in terms of their privacy?
Yeah, that's great. So the data privacy piece is very important to us. And so there's a couple protections built into this. First of all, like all the information, although it's hosted on a web server, it's encrypted on storage and transmission. And we follow the protocols to make sure that it's a secure application. The second piece is that we cannot connect individuals to a health plan or provider unless we get their consent. So if Rhonda Revere shows up at a food pantry in Upham's Corner, for example, should get a text message from Boswell saying, would you be interested in scheduling a primary care appointment at the Upham's Corner Health Center? But we can't proceed unless Rhonda actually opts into that. And so there's no disclosure without consent. And even if she does provide consent, it can be revoked at any time. It's not a barrier to services at the organization. So we make that pretty clear. Additionally, in the licensing agreement, which we give out to the food pantries, we say, look, this is a free application, basic terms of use, but actually the data belongs to the pantry. It doesn't belong to Boswell. And we make that very clear because, like, should someone, try to go seek out who Rhonda is, that's actually not our information to give out, certainly if we don't have her consent. But also it just ensures that, like, the data is still technically siloed within the walls of the pantries, but we only have permission to connect individuals when there's a consent provided. So.
And where does the funding ultimately come from for this? You said it's a free application for the food pantries.
Yeah, absolutely. That's a great question. So the funding will be coming from the accountable and managed care organizations. So the provider networks and health insurance plans that take on risk and responsibility in Medicaid. So if you look at Massachusetts, for example, like going back to those numbers, 2 million people on Mass Health, Governor Baker's budget last year was $41 billion in aggregate for the whole state. But 17 billion of that goes to Mass Health. And that's actually split up between all the different health plans providers, whether that's Tufts Health Plan, BMC Health Net, Fallon, you name it, right? And so they're taking on all the financial risk and responsibility, and their incentive is to keep people in primary care so that they stay out of the emergency department. So the return on investment to get people into primary care is tremendous. But the sickest 5% of the patients that look like Huey, who I first met in East Boston, they account for 50% of expenditures. And so they're willing to subscribe to something like Boswell to better reach and engage their members. And in time, we'd be able to share a portion of what we earn back with the food pantries using Boswell. And so we actually have our first paid partnership in Rhode Island right now. This doesn't intersect, Lauren, with Aunt Bertha. It's complementary to it more than competitive. And but Aunt Bertha is kind of the other side of the coin. So Aunt Bertha is making referrals from the clinical setting back to community resources. We're equipping the food pantry specifically with this application and trying to connect individuals, specifically those that are unengaged and not in a clinical setting, back to primary and preventative care.
Any other questions, comments?
Yeah.
A direct contact there, all right.
Yeah, I'll
Yeah,
just put my email in here.
I don't have a question other than what I just asked in the chat, but I just wanted to say, Ari, thank you for doing this work. It's innovative, it's well needed. It's a pleasure to hear that this is going on in communities throughout Massachusetts.
Yeah, thank you, Jeff. Appreciate it.
Yeah, I
Right.
think we're going to hear from Jeff and his colleague in a minute about their program, but one of the huge issues is coverage and access. And each of these connections, I think, is so vital for any of the work, whether we're talking about the behavioral health roadmap that the governor is talking, it has been, and the legislature has been putting out there, whatever it is, unless each one of these little steps is supported, none of it's going to work. So.
All right, thank you. And our second presenters, as you heard, Jeff and Amanda, are joining us from North Star Recovery Center. North Star is a new substance treatment center. It offers a full continuum of care, including PHP, IOP, behavioral health services, ongoing support, and family services in a very nice, attractive, professional facility. Services are offered, as we all need to be doing now, both in person and virtually. And North Star is currently negotiating contract with many insurance carriers. So a wider spectrum of people will be able to access their services. North Star is state licensed and it's accredited by the Joint Commission. And Jeff, who's one of the co-founders of North Star, has been working in behavioral health for the last 7 years. And his main focus at North Star is on the admissions process. And Jeff is proud to be himself. Congratulations in long-term recovery. And he, as with many people, attended multiple programs. So he really understands the compassion and empathy that people seeking treatment to their families need in that admissions process and the options that they need and deserve to have. He's often looking for community partners to make acceptable, suitable referrals. And so that even when somebody isn't a good fit for North Star, they have other places to recommend for them. And then when not doing that, a lot of his time is spent visiting and engaging with treatment professionals from other organizations. And Amanda Steverman is the clinical director at North Star. She's a licensed social worker and has herself been in the behavioral health field since 2014. She has experience with in-home therapy and mentoring, inpatient mental health and the dual diagnosis that we talked about a little bit earlier, as well as case management for insurance companies. And even though she's only been, as I said, opened its doors relatively recently, so time there has been short. She is proud of the work that she's done treating individuals living with substance use disorder, and particularly those with the dual diagnosis. Amanda's going to talk about what treatment modalities she and her team incorporate into the groups and individual sessions, as well as the additional services that North Star can provide for people seeking services and their families. So thank you both for being with us.
Thank you.
Mhm.
Do you want me to kick it off, Jeff?
Yeah, thank you. Let me just say thank you for that introduction. And I attended the meeting last month, and it was very refreshing to see such a broad collective of people meeting frequently and regularly to discuss these things. So I'm very excited to present and be a part of this. And Amanda's prepared a wonderful slideshow. So if Amanda, if you want to take it from here.
Thank you. So here we go. Can everyone see that okay?
Yep.
Okay, awesome. So we are North Star Recovery Center. We're located in Southborough, Massachusetts, right off of Route 9, off of the Mass Pike. We are pretty easily accessible to the area. We have clients that come from in and around the Framingham, Southborough area and have been able to treat a pretty good amount of people. We opened in October. Our census is currently hovering around 22 clients and growing. So that's exciting for us. And I'll just give you a little rundown of our vision at North Star. Our owners have been really involved in trying to make this vision come to light. So the idea is for us to be providing high quality care to everyone. We have master's level clinicians. We utilize a trauma-informed approach, basically person-centered, tailoring it to people as best that we can. We have recovery coaches and peer support. I think about half of our staff is in recovery themselves, and I really value that piece because it seems to have a lot of impact on clients as well. Just have people who are doing really well, have been through what they've been through. And Jeff is a really great example of that. He's really involved with our clients on a day-to-day basis, even on evenings and weekends when they need extra support. That's been really amazing for us. The idea is for us to be an in-network option for folks that also functions kind of like you would see those private facilities functioning. So we have a coffee station, snacks, beverages, TV and game access and common spaces, a really bright open space with a lot of natural light, which kind of makes it feel brighter, a place people want to come. That's really our goal. We've been really lucky to have a really good team of folks who are really bringing their all to the day-to-day, which allows us to give really high quality care to everyone. We are working on contracting with insurance companies. Jeff will speak a little bit more to that. It's a process for any of you that know how that goes. It's definitely a long process, I will say, I guess, but that's in the works. And our services include partial hospitalization, PHP, intensive outpatient, IOP, and outpatient treatment. Our PHP program runs Monday through Friday, 9 a.m. to 3 p.m. We have groups varying in topics, and I'll get a little bit more into detail in a moment. Our intensive outpatient program currently is running Monday, Wednesday, and Thursday, 6 p.m. to 9 p.m. Right now, it's all virtual. We're hoping to have it become in person sooner than later. It's a matter of for us having the staff to be able to be here in person with the clients. So that's something that we're actually getting closer to being able to do, which is exciting for us. So we'll keep you posted on that. And then our outpatient treatment is offered on a weekly basis once clients complete our continuum of care. So I have a few clients on my caseload that have stepped down through a PHP, IOP, and now individually on a weekly basis. I try myself to be very involved. I actually run our Wednesday night program, the IOP, from 6 to 9. My caseload varies between levels of care, but I really try to be very involved with our clients on a day-to-day basis as well. The topics that our groups range from, we have a lot of different books that we pull from. I've tried to create a database online for our virtual clinicians as well, ranging from CBT, DBT, motivational interviewing, behavioral activation, which also kind of falls under that CBT umbrella, and mindfulness, which if anyone has any questions about what any of those look like, I will definitely go into some more detail. On top of those kind of technical therapeutic modalities, we also utilize some vocational skills groups. We work on activities of daily living skills, socialization skills, which is helpful to have our kind of gaming space in the main area to practice sober fun with people and peers. We practice healthy habits, weekend planning, scheduling, and all of those good things. Additional offerings that we have in our program and requirements we have for clients is we have our psychiatric nurse practitioner that sees all of our clients upon admission and then on a weekly basis throughout treatment to help with medication management, side effects, anything that might come up on the medical side of things. And then we do urine screenings, which are sent in by our nurse practitioner, but we do them here as well upon admission and then randomly throughout treatment. Some people need that for court commitments, things like that, or, sober home requirements. We also like to do it just for accountability purposes for folks. We also have alumni programming that happens on Tuesday nights. So that's offered to any and all of our clients that have been through our continuum of care and they're able to come from 7 to 8 p.m. on Tuesday nights and it's more of an AA style meeting, less clinical, but it definitely hits the nail on the head for some extra peer support. One of our clinicians runs that group on Tuesday nights, and that's been actually doing really well. We have it on virtual option as well as in person because she's here. And that kind of just speaks to peer support. We have a lot of our staff in recovery. We do offer 12-step education if clients are interested. We don't identify as a 12-step program per se, but we do acknowledge that for a lot of people, that is something that works. And so our clinicians are able to walk the steps with clients. We've had a couple of clients who've been interested in that, but we also utilize other recovery models, which Jeff could probably speak better to than myself. But we offer family support. Family involvement is strongly encouraged if we're able to do that. Families contacted on a regular basis if that's something that the clients are allowing us to do, and we'll sign releases for. Oh, that was my last slide. And I apologize if I spoke fast. I tend to speak quickly, so I tried to slow myself down. But if anyone has any other questions, or Jeff, if you have anything to add.
Yeah, wonderful presentation. This is the first time I've seen you present. I'm impressed. You did a great job. One thing that wasn't mentioned that I want to be clear that we offer is medication assisted treatment through our nurse practitioner and through outside providers that I've brought to table and formed relationships with. If our clients are already on MAT and need continuation of that, we can do that. If they're struggling in early sobriety, post detox, we have medical professionals that can meet with them, engage if that's an appropriate direction to go. The biggest kind of takeaway that I wanted to kind of touch on for me, I've been doing this since 2015 in some capacity. There's being presented with an opportunity to open a center with some wonderful men, Steve and Sam, the primary owners. There was 300 different directions we could go in terms of need, direct need. The biggest one that we all unanimously, decided would kind of be our shtick, if you will, is providing a higher level of quality of care to a broader population of people. And if you've paid attention in the last 7 or 8 years to new treatment providers opening doors in Massachusetts, there's been a consistent theme of opening out of network and staying out of network and only serving the population of those suffering with substance use disorders that have commercial insurance, which in Massachusetts, and Ari could probably back me up on this data, it sounds like he's looked at it, that's about 8 or 9, maybe 10% of the population of people in need have commercial insurance. And, our focus has been, what about the other 90? It's been, yes, there are plenty of providers available for the other 90, but we think we could do better, and we think we could open, and the narrative has always been, we can't, these companies, can't both employ master's level clinical and have, bright, newly renovated spaces in nice areas and survive through Medicaid reimbursement. And we've discovered that that's simply just not true. You can, and we will. So these two options that seem to have existed in Massachusetts have been either, out of network with high quality of care, sparkling facilities, highly credentialed treatment professionals, and an abundance of amenities, pleasantries, and support, or an in-network public Medicaid option in facilities badly in need of renovations, intern or lower credentialed staff working impossible caseloads, experiencing compassion fatigue often with a high burnout or staff turnover rate, lack of support outside of clinical hours. So, our goal and our mission is to do better and to bring option 1 to the option 2 population. If that makes sense. It's about the only thing I prepared was writing out that, that descriptive. So as Amanda touched on with the insurance companies, they've got a lot on their plate coming out of, a global pandemic. Massachusetts was one of the state that was, both hit hard from a medical standpoint and also hit hard, from a restrictive standpoint. There's a lot of departments and people that haven't returned to their post or have returned with limited support. So, meeting with us, negotiating with us, and deciding to contract with us has been kind of low on their totem pole. That hasn't stopped us from being persistent. We're confident that by the end of 2022, we'll have a number of in-network commercial options and at least one public state Medicaid option contracted, and we'll be able to build from that. We do not offer or have any type of housing component. We are a true outpatient facility. So, we're obviously regionally based, and we hope in the future that once this kind of pilot model is stable and strong, we can look at other locations and demographics in need, and open up, a similar, satellite in different areas of the state, so that we can bring this to more people in more areas. So,
Thank you.
Amanda, you're welcome. Amanda talks fast and I ramble, so I feel like I've
Got a good
rambled enough.
combination going on.
Yeah.
Questions, comments for Amanda or Jeff?
Jeff, how do you get referrals?
So I'm reading here to the questions from the chat. Through advertising on Google, through visiting higher levels of care. We don't detox people. So, and detoxes most of them don't have an aftercare apparatus. So there's good relationships to build there. I come out into as many community engagements as I can and meet people and families that are in need, and make sure they know who I am. I give my number out to any and every place I can. If someone's in need, it doesn't matter their type of insurance, socioeconomic background, what they need. I am resourced in a way where I can find access to what their needs are and get their needs met. So please feel free to take my information and reach out to me with all the tough ones, and I will help find them care.
And I can say from a clinician perspective, I always like to tell people, if we have any clinicians in the room, I've sat in on countless info sessions with BD reps and, people who are saying that, reach out to me with your tough clients, things like that. Jeff is the first person that I've met that actually kind of follows through on that ask. So that's something that I can definitely back up for him. And I'm just going to really quickly show you guys what our website looks like, just because thinking of the referral piece. Sorry, where is it? We have a really good section of our website that allows people to kind of be interactive with us there. So if you if you type in northstarrecoverycenter.com in your web browser, this is what you will see. And we have our number on the top right. We also have I believe we have a chat.
Yeah, I think it's
I don't know about it if I click.
currently only working on mobile, I believe.
Okay. And it will ask, are you looking for help for you or a loved one? The number will go straight to Jeff, and he will be more than happy to help whoever gives him a call. So we have kind of a review of all of our programs and things, services we offer, just a little bit about us. So for anyone that is interested, you can definitely pass along to the website as well.
Jeff, do you have accessibility by public transportation?
We don't. There's some allowance we have to provide transportation within our catchment area, as long as we're not driving them past places that they could receive care from in the process. So we can definitely help there. And then there's a ton of other resources and nonprofits and things that that I know of that I could present that that help with transportation as well.
And I noticed earlier, I think Savina had asked if we could speak in the near future, and definitely feel free to reach out. You can reach out via email. I can send our emails as well. Jeff put his phone number in the chat, so you can feel free to use that as well.
Thank you both. Thank you.
Thank you.
We had hoped to have Devin Gilmore back today, but he had a last minute situation that prevented him from being here. So I want to talk for a few minutes just about a couple of upcoming events. Next week, SAMHSA is sponsoring a webinar on understanding the continuum of risk for overdose. What it is promising is to teach you about the range of evidence-based strategies that have been successfully implemented across a real continuum of care to prevent overdose and improve health. And it, excuse me, it specifically addresses folks with a co-occurring serious mental illness. And they'll also be talking about the impact of the pandemic. And Nora, right on schedule, is putting the link in the chat. And, you know, one of the things that I've noticed frequently as we've been looking at the notices we get regarding overdoses is the number of individuals who are suffering a fatal overdose in connection with some event, some particularly traumatic event. So we're seeing a lot of notations now, you know, parent just died, just lost a friend. Something is a clearly triggering situation. And my question is always, is there something else we in the community can be doing to address that? I think we knew our program that we had going before the pandemic with providing some information from all of you at funeral homes. You know, I've talked before about how we're providing Narcan for funeral homes. The people that go to a service and then make their way to the restroom or someplace overcome by what's happened. You know, I think there's just a lot more, people in general are much more isolated and upset. And I think there's a lot more of that happening. In addition, on April 7th from 1 to 3, the Rise Massachusetts Foundation, in collaboration with the National Harm Reduction Coalition and the Kraft Center for Community Health at Mass General, will be presenting the second in a series of learning communities focused on safe housing and harm reduction practices. This one is called the Keys to Low Threshold Housing, and it will have peers across the country talking about partnerships and approaches that they've developed to keep people housed and save lives. You'll also, and Nora's put the link for that in the chat. You'll also recall hearing from the folks at OSHA about the efforts being made within industries to address substance use disorder. And they'll be back in the next couple of months talking to us about those resources. And in the meantime, they tell us that the second annual Buildings Trade National Recovery Week begins next week. And the week of April 25th continues through that week. And this is a national substance use awareness campaign with both virtual and in-person educational sessions, and concludes with the national job site Stand Down. Recovery Week has a lot of honest conversations, invites industry leaders, medical experts, mental health counselors, and guest speakers who've had their lives impacted by addiction. And that's a great collaboration. We have a link, that link is up for us as well. And I also want to highlight a piece that BUR featured the other day. The city of Somerville has brought the folks at Fenway Community Health, led by our friend Carl Scortino, to help the city choose a location for what they are hoping will be a supervised consumption site in Massachusetts. And this discussion that's been going on for at least since 2019, when there was a recommendation from Mass to open at least one site. In the summer of 21, Somerville completed a needs assessment and a feasibility study done with researchers from Brown University. As you know, and we've talked about it here, the issues around these sites are complex and important. And ultimately, the question of their value needing to be evidence-based. There's still a lot of that to happen, whether on Beacon Hill, in the insurance industries, around practitioners who might want to provide services at these sites. But this is a step in the process. So anybody have anything else they want to raise or tell us about that they're doing? Nope. So we are actually ending a little bit early today, but again, I thank you all for being here. We will be in the upcoming sessions returning to one of the things that, as I mentioned before, is a continuing issue across the board for us, and particularly around substance use disorder, and that is people dying by suicide. Those numbers have gone up dramatically. Unfortunately, substances are frequently the vehicle by which they are doing that. And it is something that, in addition to continuing our work on the accidental overdose, we really need, I think, to be making a bigger push. So we'll be talking about that as well as a couple of other topics. But thank you all for being here. Thank you, Nora, for keeping us on track, and enjoy this beautiful day. Take care. Stay well.
Thank you.
Thank you.
Bye-bye.
Thank you.
Thank you.
Thank you.